Toprak, for talking to us today about your research. Please tell us about assessing trainees, the traditional model and emerging tools.
So the traditional model for assessing resident trainees has been in the form of in-training evaluation reports, also known as ITERs. What these are summaries of clinical performance over time based on the impressions made from informal and unstructured observation of trainees, typically by physician preceptors with or without input from allied health professionals and residents, depending on the training program. These were typically done at the end of a rotation and may or may not include a discussion with the resident themselves about their performance. And then at the end of training, these reports are compiled to create a final in-training evaluation report that allows residents to proceed to a high-stakes, typically knowledge-based certifying exam.
Okay. And you did some research on a tool for assessing trainees. Tell us about the SPR.
So the SPR stands for Surgical Procedure Feedback Rubric. This is a tool that was developed at Queen's as a means of supporting a competency design to surgical education. It performance of surgical residents and document their performance on a single operative procedure, which we've defined as a procedure from the time a patient enters a room to the time they exit, while also supporting and promoting feedback to support resident learning.
Why was this tool chosen?
The reason we decided to develop a new tool is that when we actually looked at the literature around assessment of procedural skills, we found that the tools that were available didn't adequately support the provision of feedback, which is a central component to competency-based medical education and the assessment systems that support it. Lots of tools are out there in the literature, but validated intraoperative tools are less common. And those that are validated have limited evidence for their validity. Mm-hmm. They typically use things like checklists and rating scales, numerical rating scales, also known as likert scales. And these have limitations that affect their usefulness as both an assessment tool and as a method of providing feedback. Sure. So starting with checklists, they really just tell us what a resident does or does not do, and doesn't really give us a good idea of the quality of the assessment or the quality of what was done, nor does it provide residents with feedback on how to improve their performance in the future beyond telling them what they missed. Likert scales use implicit standards of competency. Explicit standards of performance. My apologies. And what that means is that a 3 for me doesn't really necessarily mean the same thing as a 3 for you. So that variability in rater assessment makes it very difficult for our make these assessments, and for learners it significantly reduces its usefulness in terms of feedback.
Sorry, I lost your audio for just a second.
Sorry.
What happens with the why do you say you don't use that one?
So the reason we didn't really like the Likert scale was that it uses implicit standards of competency. Mm-hmm. So what a 3 for you is not necessarily the same thing as a 3 for me, and that variability in assessor responses make these types of assessment tools difficult for programs to make sense of the data, and for residents it limits the usefulness of the feedback that they're getting.
Okay. And what did your study find out about SPR?
So I'd like to highlight 3 major findings from the study. The first one is that it provided us with some evidence for construct validity. When we looked at the internal structure of the SPR, we found that it was measuring 3 constructs: operative performance, technical skills, and intrinsic competencies. This is really what we set out to do when we started developing the rubric, so it shows that it's measuring what was intended. The second major finding is that the SPR is actually quite good at distinguishing between the intraoperative performance of residents based essentially on their postgraduate training year, which provides us with discriminative validity evidence. And then The third major finding is that this study has actually allowed us to start the process of looking at transferability of this tool. The rubric was initially developed for general surgery. But when we piloted this tool, residents in other programs and faculties in other programs saw us using it, and they liked it so much that they actually wanted to incorporate it into their own programs. And so when we studied this, we studied it across multiple surgical training programs. And what we found is that there is some transferability of the tool to other programs, but that we can improve the transferability by looking specifically at the technical skill component and intrinsic competency components of the rubrics, and to make the more full to those programs.
To make what?
More meaningful for those programs.
Okay. So where does this research take us? What else would you like to study or see studied?
So this research provides us with evidence for the use of the surgical procedure rubric in particular, and rubric-based assessment tools in general for supporting a competency design to medical education. It provides us with evidence for the discriminative validity of the surgical procedure rubric, but to truly support a competency-based design, we need assessment tools that are able to monitor resident performance over time to create learning trajectories. So the next phase in our analysis is going to be to look at the ability of the rubric to capture changes and patterns over time for individual residents. In addition, we need to look at the transferability of the tool. So if anybody is interested in we're happy to start looking at that, the use of the rubric in different institutions. And then finally, we need to start making sense of what the results of these tools and other assessment tools within an assessment system to support competency-based medical education, and how they can be interpreted to make judgments on a resident's progression towards competencies for the purposes of entrustment and progress, promotions, and eventual credentialing. My apologies.
And I just learned that competency-based advancement is coming to Canada. Is that the case?
Yes, the Royal College has introduced a competency by design project that has a clear pathway for turning all of our postgraduate medical education programs into competency programs by, I believe, 2020, sometime in the 2020s.
Interesting. Okay. Well, we're going to see you in Seattle, right? You're presenting at Surgical Education Week. Sorry,
you cut out on me. I apologize.
We're going to see you in Seattle. You'll be presenting at Surgical Education Week, correct?
Yes, I will be presenting Thursday, 23rd at 3:30 p.m.
Very good. We look forward to seeing you there.
Okay, great. Thank you.
Bye-bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.